Okay, I think we'll go ahead and get started. Good afternoon, everybody. Thank you so much for your participation in our first colon cancer conversations webinar in March, which is Colon Cancer Awareness Month. Our first webinar today covers the basics of colon cancer. So you're going to learn about the risk factors, the signs and symptoms, the preventative screenings, just things to look for, and also the supports that are available to you. My name is Danielle Harmon, and I am the Community Development Manager for Appalachian Regional Healthcare, and I'm going to be your moderator today. Some housekeeping items just before we get started. The Q&A today is going to be open as well as the chat box. Please feel comfortable in asking questions there. If you have asked a question on email beforehand, I do have those in front of me. If they're not answered within the presentation, then I'll ask those for you when we get to the end. Our experts today cannot answer specific medical advice or referrals. So if you need a referral or you have specific medical questions about your own health, please contact your medical care provider. And if you do not have a primary care provider, please visit us at arh.org where we can find one for you. Our first speaker today, we have two speakers in our webinar. Our first presenter is Dr. David Stuart. Dr. Stuart originally is from the Bahamas, and he completed his undergraduate degree at Boise State University in Boise, Idaho, and his medical degree at the Howard University College of Medicine in Washington, D.C. He moved to Appalachia and the mountains, which we are grateful for, to complete his general surgery residency at Marshall University in Huntington, West Virginia. And then he has worked at Beckley ARH in Beckley, West Virginia since 2007. He is the chairperson of the Department of Surgery for Beckley and Summers ARHs. And he also teaches at Avalon School of Medicine and Lincoln Memorial University College of Osteopathic Medicine. He has an interest in colon cancer screenings and treatment, and he is certainly the expert that we need for today's webinar. So thank you so much, Dr. Stuart, for being here today. I am going to hand you over the reins. I'll pop over at the end of your presentation. I'll pop back up and introduce our next speaker. So please take it away.
Sure. Well, thank you, first of all, for having me. So what we're going to go over, hopefully briefly, is statistics of colon cancer, and not only the US, but West Virginia and Kentucky. Also looking at signs and symptoms of colon cancer and also screening modalities we have. So colon cancer is actually one of those cancers that is preventable. Not too many cancers are preventable, but if found early, colon cancer potentially could be cured or even eliminated before it becomes malignancy. First I'm going to talk about is the anatomy of the colon. So the colon is divided into several segments. We have the ascending colon, which connects to the ileum or small bowel, which is on the right side of the colon. Then we have at the hepatic flexure to the splenic flexure, we have the transverse colon. And on the left side, we have what's called the descending colon. The last segment of the colon is called the sigmoid colon, which is where most of the colon cancers in the old age actually occur. The function of the colon actually is to absorb water, electrolytes, and eliminate feces. And colon cancer is actually the third leading cause of death in all sexes, but it's one of the few preventable cancers that we have. And here we have graphics showing the distribution of colon cancer new cases in the US in 2021. In males, prostate was the number one, and females, breast was number one. Lung was number two in both sexes. Colon cancer was number three in both males and females. So here we have a table showing the distribution of the number of colon cancers, new cases, and deaths in 2020. So you can see under the age of 50, there's a marked difference between the number of incidents of colon cancers between 50 and above and less. You can see between the age of 0 to 49 is actually 17,000 per year. Once you get above 50, it jumps dramatically, and 65 is even higher. So that's why we can screen and find these colon cancers early. We eliminate the potential occurrence as well as the long-term effects and also death and mortality. See, here we have looking at age-specific colon cancer incidence. Again, you can see at the cutoff age of 50, there's a marked difference between the numbers in terms of 100 per 100,000. We have 45 to 49 years of age is actually 33.1 per 100,000. Once you get above 50, it jumps to 59.5. So again, that's why most of the guidelines recommend at the age of 50, we start at screening. Now there's new talk about actually starting at the age of 45. And that's still debatable, but you can see where the marked difference between less than 50 and above 50. Now here we look at the colon cancer incidence and mortality. This is between 2012 and 2016, and the mortality is between 2013 and 2017. For Kentucky and West Virginia, unfortunately, we do badly in both incidence as well as mortality. So we're ranked in the top between 44 to 49.2 per 100,000. And in the deaths, we're actually 16 and above. So in all those categories, we're actually worse than the rest of the country. And looking at, this is statistics from the West Virginia Department of Health and Human Resources. Colon cancer incidence rate in 2020, looked at the incidence as well as the age, over the age of 50, as well as those who were diagnosed over 50 in terms of their late stages. So we see that we have about 1,100 per year average, all ages. However, once you see above 50, most of those cancers actually occur in people that are over the age of 50. What's even more staggering is that half of those people, they're found over the age of 50 to be late stage. So we find these people earlier, we can actually potentially, one, reduce the morbidity, mortality, and actually even save lives. But if we don't find them until they're late stage, there's not a whole lot you can do. And I'll show you later on that the later you find the colon cancer, your 5-year survival rate dramatically drops. And again, in table 2, we see that in West Virginia, per 100,000, we are 47.6 in terms of incidence population, which is markedly higher than the rest of the population. Once above the age of 50, it's even more staggering in terms of the numbers that we have per 100,000 per population. So as I was saying, in terms of your 5-year survival rate, this table shows that for colon cancer for all stages, you have almost a 70% 5-year survival rate. And this breaks it up into actually based on age, actually a local, if you have a local disease, your survival rate is actually almost up to 94%, is actually 94%. But once you start getting regional and distant disease, your survival rate drops dramatically. Regional disease is 78%, distant disease, you're almost down to 10%. So if we can catch it early, you potentially have a cure or even preventable if you actually find a small polyp. And now we break it up by race and ethnicity. You can see that in all stages, non-Hispanic Blacks have the worst 5-year prognosis, both for local as well as region, as well as distant disease. So we have a lot of work to do in terms of the racial disparities, but I think education is one of the first part we need to actually focus on. So first of all, colon cancers, they all occur as polyps. So what's a polyp? So a polyp is a mucosal outgrowth. It consists of the mucosa, which is the lining, as well as the submucosa that grows into the lumen on the inside of the colon. We have a number of types of polyps. Some of them have low malignant potential, but some of them have pretty high. So we have what we call inflammatory or pseudopolyps. These are common in inflammatory bowel disease. So these don't have a significant malignant potential. However, ulcerative colitis and Crohn's disease, they actually do increase your risk of colon cancer, not the polyps, but the actual disease itself. Hematomas, these are associated with a special type of disease called Peutz-Jeghers juvenile polyposis. They have a low malignant potential. Adenomas, these are the ones that we tend to see the most. They're classified as tubular, tubular villus, and sessile serrated. The villus have the highest risk of becoming malignant. So here's a picture of a polyp. Pretty dramatic, but this is how we classify the polyp in terms of whether it's pedunculated or whether it's flat. Pedunculated means it has a stalk. And these actually are better because if this does come out to be pre-malignant or malignant, you could potentially eliminate the colon cancer, because if you take the entire stalk and there's nothing left behind that's malignant, you've cured that patient from potentially having colon cancer and distant disease. The other types of polyps are what we call sessile polyps. These have a broad base, so these are a little more difficult because even if you biopsy it, you may still have a portion of that polyp left behind. If it's pre-malignant and it's left behind, and it's no longer, it isn't biopsied or removed completely, that could potentially become colon cancer. So here again, these are the different types of polyps that we have: the tubular adenoma, the villus adenoma, hematoma, inflammatory, and hypoplastic. So the ones we worry about the most are the villus adenoma. They have a high potential for malignant conversion, transformation. The tubular adenomas, These have a lower, but these require endoscopic surveillance and removal. Again, if we remove these, they don't become colon cancers. So how do these polyps become cancer? There are several mechanisms in terms of how they occur. One of them is, it's kind of technical, but it's the APC gene. It's a tumor suppressor gene. If you have loss of this gene, this increases your risk of colon cancer creation. There's a KRAS mutation, which also increases your risk. And then there's also a loss of a tumor suppression gene. These all make normal cells become abnormal. And then once that continues and multiplies, then you increase your risk of colon cancer. And these are some of the mechanisms. I don't think we need to go over those, but one thing that's interesting is that one of the mechanisms they believe is what they call a COX-2 overexpression can cause you increased colon cancer. What's interesting about this is that aspirin does act as a protective mechanism for prevention of colon cancer. This is the mechanism of that colon cancer conversion. So here we look at staging colon cancer growth. So again, if you find these polyps when they're small, just on the mucosal surface, you remove it, that person's cured. But as you see, as they get bigger and bigger, they start invading into the tissue, into the muscle, outside of the tissue. And once they get into the lymphatic tissue or out into the vascular system, there's not a whole lot you can do because now you're basically the cat out of the bag, so you're trying to catch up to it. So if they become dispersed into the lymphatic system or to the liver or to the lung, you're not only treating the colon cancer, but now you have a systemic disease, and the chances of your survival are a lot less. So the symptoms of colon cancer. So polyps are typically asymptomatic, but occasionally a patient will come in because they have rectal bleeding, and they come in because of that reason. Lesions, in terms of where the polyps are, gives it different symptoms. On the right colon, you may have what they call a occult blood loss, which means that it's not something that's visible. You may have dark stool, but you may be anemic, and that prompts further workup because you may have a polyp or cancer, but you won't know because it's not symptomatic. Some people have weight loss. The problem with these polyps or tumors is that they remain asymptomatic until they become advanced. What that means is that on the right side of the colon, it's not until they become symptomatic, means that the tumor's gotten so big that now you're having pain, you have occlusion, you have bowel obstruction, that you notice these symptoms, and now you have an advanced disease without even knowing. The left colon, they tend to have more macroscopic, meaning that they're more visible. You have bright red blood per rectum. You may have a change in the color of your stool. You may have a change in the caliber of your stool. This is because the lumen is now becoming more narrow. Right now, the recommendations are for the age of 50 to start colon screening. However, in high-risk individuals, these individuals are persons that have first-degree relatives. They recommend starting screening actually 10 years before that person actually had the diagnosis of colon cancer. Or individuals that have what they call familial adenomatous polyposis. These are high-risk individuals that require more frequent screening in the regular population. The average risk recommend colonoscopy screening every 10 years, starting at the age of 50. And I'm going to go over some of the recommendations right now in terms of screening. So colonoscopy is pretty much the gold standard for everybody. It examines the entire colon. You can remove a polyp. So it's not only diagnostic, but also therapeutic. If you have a polyp, remove it, you've cured that patient. You can diagnose other diseases. If you have an abnormal test, colonoscopy is still going to be what you're going to have to go to. So a lot of people recommend just going for colonoscopy. However, there are other modalities that can be used. We have CT colonography. They recommend that. Actually, I have the screen here. They're mainly for diagnosis. The reason why you say diagnose is because you can diagnose it and detect it on a colonoscopy, on the CT colonography, but you can't take it out. Flexible sigmoidoscopy is another modality that can be done without having to sedate someone. The problem with that is it only looks at the low portion of the colon. They recommend every 5 years. You can even combine that with fecal occult testing, which is more, it's a better test combining the two. The other modalities are, I think we're going to talk about this later on, is the fecal immunochemicals test. There's also the occult stool. We also have Cologuard, which is another test that actually checks for the DNA for polyps and most colon cancers. But again, if these tests show any abnormalities, you're going to resort to doing a colonoscopy. One thing that's interesting is that our diet does play a part in terms of the occurrence and treatment of colon cancer. They've showed that high fiber, high fat, and low fiber diet actually is involved in the development of colon cancer. They've showed that high fat, high meat, high saturated fats from meat, different products actually does increase your potential for development of colon cancer. And they've showed that high saturated vegetable oils actually do act as a protective mechanism prevention of colon cancer. So fish oils, consumption of eating fish actually is protective. Calcium intake is also protective. And even some of these vitamins such as selenium, vitamin A, C, and E, they have a protective effect. Alcohol actually, as well as tobacco, also does play a part in prevention of colon cancer if we stop them. Alcohol intake has been suggested and associated with increased risk of colorectal cancer. Smoking, especially at a young age, increases your risk of colon cancer. What's even interesting about the smoking is that you have an increased mortality after you've been diagnosed with colorectal cancer. Not only do you increase the risk of development of colon cancer, but you also increase your mortality after you've been diagnosed. Again, what we said about the COX-2 inhibitors, aspirin, that has been shown to stop the progression from a polyp to the carcinoma sequence. And these are references. There's a lot of information, especially from the American Cancer Society, CDC. I had help from some of my medical students. The big point is that if we can find find a polyp early, we could potentially cure someone, potentially and reduce their risk of morbidity, mortality, especially if we find it early. Once it's late, your mortality, your 5-year survival drops down to almost 10%. So everyone, get your colonoscopy.
Early detection is the key, for sure. Thank you so much, Dr. Stuart. And so I'm going to do a Q&A at the end. If you'll hang around, we'll ask some questions for you at the end. But right now, I'm going to let Ashley Teague take over, who is our next speaker. Ashley is a regional cancer control specialist with the Kentucky Cancer Program. She works in the Kentucky River Area Development District, which is often based in Hazard and around Hazard. Her role, Ashley works to reduce cancer incidence and mortality by promoting cancer education, research, and service programs, as well as providing local leadership for cancer prevention and control planning, implementation, and evaluation. She works directly with many state partners on colon cancer programs and grants, including the Kentucky Colon Cancer Screening Program and the Public Health and Health Systems Partnerships to increase colorectal cancer screenings in clinical settings grant. And Ashley, you were right, that is quite a mouthful. I'm just going to let you take over. And again, we will ask questions at the end. So Ashley, please take the reins over and share your screen. Oh, thank you.
Thank you, Danielle. I told you that was a mouthful. In all, I work for the Kentucky Cancer Program. I am based out of Hazard and cover the Kentucky River District. There is one of me in every area development district in Kentucky. And so what we do, our overall goal is to reduce cancer incidence and mortality. We just want to see our communities healthy. So what I'm going to talk to you all about today are some of the at-home screening tests. When we're out in the community and we're talking about colon cancer awareness and screening, a lot of people aren't aware that you can do screening tests at home. And if they are aware, they think it's very gross. So what we try to do is educate people on how you actually do these tests. And they're really not as gross as you think that they are. And so they're definitely worth doing. And I will note that these tests are more for people that are average risk. If you are at a high risk for colon cancer, we totally recommend that you start with the colonoscopy. Because just like Dr. Stewart said, they can go in there and if they see any kind of polyps, they can take those out and immediately reduce your risk for cancer. So definitely go for that. If you're average risk, that means you have no family history, you don't have any kind of colon issues, then this is what we want to talk to you about. And so the first one is called the Fecal Immunochemical test, but to make life easy, we refer to it as the FIT test. These are tests that you can get at just about any primary care provider, and it is an at-home test that uses a stool sample, and that's kind of where people get grossed out. They don't want to have to do this. This is just too nasty for them. But it's really not that bad. And what it does is just check for hidden blood that you wouldn't see just using the bathroom. The good thing about these tests is there's no medicine or food restrictions before you take the test. I know with the colonoscopy, sometimes, you have to do the prep, you have to stop certain medicines. This is a little bit easier when it comes to that. These tests should be completed every year. And if the test is positive, that does not mean that you have cancer. It means you need to follow up with your provider for further testing. It's like Dr. Stuart said, if it's positive, they're probably going to recommend you come in for the colonoscopy because there's blood in your stool and we want to find out why. It could be one of the other polyps that he mentioned that aren't precancerous. It could be hemorrhoids. It could be any number of things. So it does not mean you have cancer. It just means let's figure out what's going on. So we wanted to share this video, and let me tell you, I searched YouTube for the perfect video of how to do a fit test that wouldn't gross anyone out, and I did the best I could, but this will show you what will happen. Now, there are different fit tests. Not every fit test looks identical, but these are a very popular brand of fit test. And just to see how easy this is to do at home, we hope it would encourage anyone who does need colon cancer screening to do one of these. Please let me know if you cannot hear this. Hopefully you can.
No one really likes to talk about it, but a little bathroom talk may save your life. Having a reliable way to detect colorectal cancer early can make a big difference. The Fecal Immunochemical Test, FIT screening method, is the standard of care for early detection. To get your test, visit your physician and request a FIT test. Once you receive your patient pack, double-check you have all the contents that should be in your pack. If indicated, clearly write your information on the bottle or requisition. When you are ready to have a bowel movement, place the collection paper inside the toilet. Collect your stool on top of the paper. Twist the green cap on the sampling bottle to open the bottle. Collect your stool sample before the paper sinks by scraping the surface of the stool sample with the wand attached to the green cap. The grooved portion at the tip of the wand should be completely covered. Now, reinsert the wand into the sampling bottle and snap the green cap on tightly. Do not reopen. Okay, just finish your business and flush the biodegradable collection paper. Double-check that you have recorded the collection date on the bottle. Then, wrap the sampling bottle in the absorbent pad and insert into the biohazard bag. Place the biohazard bag with your sample inside the return mailer. Seal the return mailer securely and drop the prepaid mailer into the mail. Your sample is perishable. Mail your sample promptly, ideally the same day you collect it. You will be notified by your medical provider about your test results. If your result is positive, it's important that you contact your doctor to schedule follow-up testing. If your result is negative, mark your calendar for 1 year from today to take this annual test again. Get screened with FIT today.
So one thing I would like to point out is that not every clinic or wherever you go to your primary care provider will do the mail-in FIT. Sometimes you actually have to take it back to the facility, but some are starting to do the mailing back in, which is a lot easier on the patient. Okay, so the next test is the Cologuard. And is the Cologuard. And Dr. Stewart made a little reference to this earlier. And this was actually similar to a FIT test, but it also looks for DNA. So it checks for the hidden blood, but also abnormal sections of DNA that would be in your stool. Colon cancer and even some of these polyps often have abnormal DNA. And so that's what it's looking for in your sample. And again, just like the FIT test, no medicine or food restrictions for the test. The difference is this test should be completed every 3 years as opposed to every year. So a lot of people like that option. And also, as you'll see in the video, Cologuard, which is the company, the only company who does these tests right now, will actually mail you the kit for you to do, and then you mail it back. So you don't even have to leave your house other than to talk to your primary care provider. If the test is positive, again, it does not mean that you have cancer. It just means we need to follow up and figure out what's going on, and you most likely will have a colonoscopy. So for this video, I wanted to use the video that Cologuard actually had on their website, but they have some restrictions with that. So if you are interested in seeing that video, it's a lot like the one you just watched, is very animated. You can go to Exact Sciences website, Cologuard website, and watch it. This is actually the Cologuard CEO, I believe, and he's demonstrating how you would do the Cologuard test at home.
This is how easy colon cancer screening can be. When you go to your doctor, doctor orders a Cologuard test. That automatically triggers UPS sending a collection kit to your home. So that goes to your home. You open up the collection kit once you receive it, and you take out this bracket. This bracket goes over the toilet bowl, and the toilet seat comes down over. After that occurs, you take this collection device and slide it in there, and then the magic moment comes and the patient provides a sample. After providing a sample, we need to collect a separate sample, a very small sample, to test for blood in the patient sample. And you simply take a small sample and put it into this vial, and take this vial and put it back into the box. After doing that, the patient simply takes this preservative and pours it over the sample and throws away the empty vial. Then the patient screws on the lid to secure the sample, takes the whole collection kit, puts it back into the box, zips the top, puts that back into the box, picks up the phone, calls UPS, asks UPS to come back and collect this box. This box then is shipped directly here to the Exact Sciences laboratory in Madison, Wisconsin. And from there, the testing occurs, a result is generated, and a lab report goes directly to the patient's physician. And that physician then is able to call the patient and tell them the results of their colon cancer screening. It's that easy.
Okay, so as you can see, that is pretty easy as well. And you will get a result whether you do the FIT test or Cologuard. You will get the results from your primary care provider, and they will let you know whether it is positive or negative. I will say that most insurances cover these as a colon cancer screening, so that is always a plus. What we really want to talk about now is what happens if you don't have insurance, or what happens if you have insurance, but you have really high deductibles and it's just something you can't afford. Well, luckily in the great state of Kentucky, we have the Kentucky Colon Cancer Screening Program to address just these issues. And so you will see, if you're a Kentucky resident, you can qualify for free screening. If you are uninsured or have high deductibles, you have a low income. And let me say that when it says low income, it's really not that low. I was actually shocked when I saw what the income guidelines are for this program. And I feel that a lot of people in Kentucky are going to qualify that will be surprised that they qualify. Also, if you have a family member that's been diagnosed with cancer or had polyps, you also qualify, or you have symptoms. And so what this program does is not just the FIT or Cologuard, this actually does colonoscopies too. So all colon cancer screenings should be covered by this program. And we are actually really blessed because Cologuard donated, I believe, 1,000 Cologuard kits to this program. So if you qualify for KCCSP, you can actually get a Cologuard as well. And luckily, we are doing this program through Kentucky Cancer Link. They're a great partner in this state, very, very good at patient navigation. And so what you will do is call this number. They will go through all of their questionnaires to see if you qualify. If you don't qualify for this, they actually have some other programs that you might qualify for. So we really, really recommend everyone calling this number. The good part is if you do qualify for this program, your colonoscopy could actually be done locally. They have a lot of contracts with providers throughout the state. So this isn't a let's travel to Lexington to get a colonoscopy. You could be getting a colonoscopy at the hospital in your community. So definitely if you are uninsured or underinsured or know anyone that is, please give them this number. We are so excited we have this program to offer to people. And we hope that we can use this to increase the screening rates in Kentucky.
Thank you so much, Ashley. So I think we have come. Are you finished, Ashley? I'm sorry, I should have said that before.
Yes, I'm trying to stop share.
That's okay. I just wanted to make sure before we moved on to Q&A, and it looks like, let's see. Oh, Melissa Carr is on the call today, and she says, "Thank you so much, Ashley. Happy to partner with you from Kentucky Cancer Link." So Melissa is from our Kentucky Cancer Link here in Kentucky that covers our region and is over the Kentucky Colon Cancer Screening Program, as Ashley was just talking about. And hopefully we will have that program up and running at a few of our Highlands, our Appalachian Regional Healthcare places, and Highlands in Prestonsburg is probably going to be one of those. So exciting news coming through just this morning. So I think that we can move on to our Q&A, and we did have a few questions, but most of those were answered during our presentations. But one of them was, has the age of cancer screenings changed? Now, I know here in Kentucky, of course, it has changed. We have moved from 55 to 45 here in Kentucky, and almost all of our insurances now cover 45. So yay, and that's a great thing. Dr. Stewart, I'm not sure about West Virginia. I was kind of searching quickly, and it looks like you guys, most of your insurances should be covering that, but it's not across the board yet for 45. Is that correct?
Right now, it's not across the board. There's a lot of talk, and some of the places have started in different states, but there really isn't any consensus yet with all the organizations, but there's a big push to lower it to 45.
Okay, thank you. So here in Kentucky, definitely 45, West Virginia to be determined, at least by 50. So in Kentucky, 1 in every 5 people that's diagnosed with colon cancer is less than 50 years old. So our next webinar that's going to be held on Friday at 2, if you haven't signed up, please sign up, go ahead. But that one's going to discuss the rise in younger rates in all of Appalachia, not just in Kentucky. But we have a very big rise in colon cancer, colorectal cancers, and people that are younger than 50. So we'll be discussing that just a little bit on that one if you want to log in. So something else that I wanted to talk to you guys about is this stigma that people have against colon cancer screenings, specifically colonoscopy. Everyone is scared of colonoscopy and scared of the prep. And I hope that maybe, Ashley, if you want to talk a little bit about what you know about our colo preps and how it's probably not as bad as what people expect.
That is the #1 reason we hear people do not want to get a colonoscopy, is because I've heard that prep is awful. And it's probably not the most pleasant, but I joke with everybody and I say, I'm a mom of 2 kids. And if it's going to get me time in the bathroom by myself, and then I get to nap while I get my colonoscopy, sign me up. But here's what I do say, is the prep isn't pleasant. And that, I mean, it's come a long way. I've heard many people say that it's better than it used to be. It used to be really bad. Now it's not so bad. But what I will say is this, is that prep for 1 day is far better than chemo at any time. It's far better than stage 4 colon cancer on down the line. It's, you have to feel better afterwards. I mean, you get cleaned out, you get your colonoscopy. If they find polyps, they take them out. Your cancer risk is, gone. And that has to be enough in my mind. But I have heard from many people in the community, either they don't want to do it because it's awful, and then the people that have done it say, you know what, that prep wasn't as bad as what I thought it was going to be.
I've heard that from my own family. It's just not as bad as it used to be, or it's not as bad as I thought it was going to be. And as Dr. Stewart was mentioning, early prevention is the key to survival. So the earliest that we can catch something like this, and not just for colonoscopy, but all of your preventative screenings, get those preventive screenings. You're your best healthcare provider. You have to take care of yourself. There's nobody else that's going to do that for you. So very, very important. Dr. Stewart, do you have anything to add to that as far as stigma and maybe why your patients don't get colonoscopy as they should?
I think a lot of people don't want, well, it's an embarrassing procedure, so that's a given. But I always tell them I'd rather have the prep as opposed to being embarrassed, not having it. Now you have a colostomy, or you're, like you said, going through chemo. If it's late stage, that embarrassment may have now cost you your life and potential time that you would have spent with your family. So that embarrassment is not equivalent to you not being alive.
Absolutely. So another question, I know we've talked about this on our talk, but if you can just go over really quickly, high risk versus average risk, Dr. Stuart.
So high risk, anyone that has a familial syndrome, disease, those individuals don't fall into the normal screening program. Those individuals actually would have to get actually starting earlier. So instead of 50, well, even 45 now, they would probably start at 35, even 40 years of age, because if you already have a predisposition to become cancerous later on, your clock has already started. So you need to start your screening a lot sooner. For the most people that are average risk, the start is actually at 45. So if we can find it earlier, again, prevention, you can eliminate with conversion to malignant tumor.
Thank you so much. So Ashley, do you have anything at all that you would like to add about family history? I know that's something we're going to talk about again on Friday, but just to make sure.
Yeah, so which family history hits home with me because my father-in-law actually died of colon cancer. He was, his first colonoscopy was at 57, in which he was diagnosed with stage 4 cancer. He had never had a colonoscopy before. He went in and because he was presenting with symptoms. And so that's when he finally went. It had already spread to his liver. He had 5 good years, hard years after that. So what I know now is my husband is at higher risk because his father was diagnosed. His father was diagnosed at 57. So, no, it was 54. So my husband goes at 44. I actually made my husband do a fit test. I mean, my husband is only 37. So I was like, here, you're going to do a fit test. Like, you're going to do something right now. Because I watched that battle go on and my husband watched that battle go on. And he's even talked lately, I probably need to go ahead and talk to a doctor about a colonoscopy. And so that's the thing. We live in Eastern Kentucky. We have high rates of colon cancer. And so many people in this area have family history, and what they aren't aware of is that family history puts them at high risk, which means they need to get screened sooner. I mean, we have a hard time getting people screened at 45 and 50 when really they should be getting screened even before then. So that's a big push that we want to do just in the cancer world in general is, if you're at high risk, let's start screening.
Mm-hmm. I think a lot of people don't understand that importance of their family history, or maybe not even know, their full family history of who has had cancers. Or we hear a lot of times it was just all over. They had just cancer all over, so you just have to educate yourself so you know what to look for yourself. Something else that I wanted to talk about a little bit was the difference. You mentioned that Fit Kit, of course, is every single year, and that the Cologuard is every 3. So Fit Kit does not do DNA, but Cologuard does, right? So I know also, we talk about colonoscopy and how people don't want to do it, and there's a stigma and it's so hard, but Fit Kits or Cologuards are, an easier alternative, and it's just for average risk. Do you have any other reasons that people might take a Fit Kit or a Cologuard or an alternative way of screening as opposed to a colonoscopy? Either of you.
I mean, I feel like people take it because it's easier. It's something they can do at home. The prep is not there. I think that's a big reason. But I will say this, it's hard to get anybody to do, it's hard to get some people to do any colon cancer screening. So our thought is, let's get them what test they will take. I mean, if it's going to be a fit test, let's start there. And if it comes back positive, that's when we really start pushing, okay, you need this colonoscopy and this is why. And we hope that a positive result from that opens their eyes to, okay, I really do need this. Because a lot of the mindset is, if I don't have symptoms, then I'm okay. There's nothing wrong, so I don't need a colonoscopy. But that positive test is kind of an eye opener. And so it opens that discussion to the colonoscopy further. I know the colonoscopy is gold standard and we would push that. I mean, if we could get people to do that, we would push that and push that. And what we're seeing now, you know, Kentucky has really increased their colon cancer screening rates, is that we're at that pocket of people that we can't convince to do any screening. So we do what we can to get them to do any of these tests that would qualify as a colon cancer screening. I mean, Dr. Stuart probably encounters this more with patients and trying to, you know, talk them into doing any test.
And I think a lot of that's education, and that's what we try to really push it. Not so much from my part, because usually when they come to me, they've already seen their primary care physician and they're kind of leaning towards colonoscopy. But educating individuals, and even now we're being graded on how much of our screening protocols we're actually initiating. Colonoscopy is one of them that you're being graded by. So every time a person who meets those criteria, we need to start educating them. And sometimes you'll hear, oh no, maybe a couple of years, but if we start telling them and showing them that this is potentially curable, and I would say there's no point of being like the ostrich, you're putting your head in the sand. Just ignoring it doesn't make it go away. If you can find that there's nothing wrong, you don't need a colonoscopy for 10 more years. At least that's off, you can check list that, take that off the list. But if you don't and you have something that's brewing, when you do discover it, it's basically a bomb that's gone off and you can't really put it back in.
Absolutely. And colon cancer, you may have symptoms that you may not know about or you may not notice. You know, not everyone notices if they have blood in their stool, and they would need that test to see, you know, one of our fit kits or Cologuard, and then move on to the colonoscopy then. But some of those symptoms, even weight loss, a lot of people don't notice until they have lost a ton of weight, you know, so you don't want to get to where you're stage 4 and instead of catching it early. So lastly, any takeaways from either of you that you would like our participants to hear? And again, this is going to go on social media as well. So you have our participants on live now, and then our participants that are going to watch it on social media. So any takeaways about colon cancer that you may have not spoken about before, or that you want people to remember most?
I think the big takeaway is making sure that you actually get your screening test. Because if you're sure that there's nothing going on, then that's one thing that's off the table you have to worry about. But if you don't, it may come back to bite you.
Absolutely. Any takeaways, Ashley?
I completely agree with that. If you are 45 or older, please, please, please get screened, because like it's been mentioned, there are no symptoms in early stages of colon cancer. And so if you can go in and have that screening and find the polyp that's precancerous and take it out, you've eliminated your risk. And also learn your family history. There's so much, and it's like you said, we just know that Granny had cancer. We don't know what kind. And so learn your family history. And so that way you know what you might be high risk for. And so that's something you could keep an eye on in your own health.
Perfect. Thank you guys so much. We had a comment from Melissa Carr, who's one of our community partners again, and she says the best test is the test that gets done. And that is just so true. Whatever you can do to up your prevention and better your own health, any test is great. So thank you so much, Melissa. And with that, I think that we end our webinar. We don't have any other questions that I see on our Q&A, and everything was answered from our email. So thank you guys so much, Ashley and Dr. Stewart, for being a part of our webinar series. I'm sure we'll see you again on the webinar series, hopefully soon, because you were great, and I really appreciate you. So thank you guys so much.
Thank you.
Thank you. Have a great rest of your day.